Hello, I'm Karen Reckamp, Division Director of Medical Oncology and Associate Director of Clinical Research at Cedars-Sinai in Los Angeles. Today I'll be talking about EGFR tyrosine kinase inhibitor resistance, specifically targeting MET amplification and MET alterations. MET-based resistance mechanisms to EGFR tyrosine kinase inhibitors have been reported and can occur in anywhere to 5 to 15% of patients. Both MET amplification and other MET-based alterations have been described in EGFR TKI resistance, both following first-generation and second-generation EGFR TKIs and following third-generation such as osimertinib. Looking back at the multiple acquired resistance mechanisms to EGFR TKIs, we see here that mechanisms differ by line of therapy, and MET amplification has a broad range in those who have received both first generation or second generation followed by osimertinib versus those who receive osimertinib in the front line. The range is about 5 to 15%. We'll start this one with a case. A 62-year-old, never smoking female presented with left-sided chest pain and productive cough. A chest x-ray showed a left upper lobe density and a left pleural effusion. CT of the chest demonstrated a 7.4 centimeter left upper lobe mass with bilateral pleural effusions, left greater than right. There were nonspecific prominent mediastinal lymph nodes up to 12 millimeters in the right paratracheal region. She underwent thoracentesis and pleural biopsy that demonstrated a moderately differentiated adenocarcinoma, TTF1 positive, PD-L1 0%, and GS revealed EGFR mutation in exon 19. MRI of the brain was negative for metastatic disease, and a PET-CT showed a 1.8 centimeter left supraclavicular lymph node, 9.1 centimeter left upper lobe mass with increased FDG uptake. Osseous metastases were seen in multiple areas. She was started on osimertinib in March of 2018. She experienced a partial response and did well on osimertinib until about September 2020, when she developed progressive dyspnea. A CT scan of the chest demonstrated growth in multiple lung nodules, and increased left pleural effusion, and bilateral axillary lymphadenopathy. She underwent diagnostic and therapeutic thoracentesis, which showed malignant cells consistent with adenocarcinoma. She also underwent a left axillary lymph node biopsy, and pathology showed invasive, moderately differentiated adenocarcinoma. Immunohistochemistry was positive for pan-keratin, napsin-A, and TTF1. NGS revealed an exon 19 deletion in the EGFR gene, CDK4 amplification, MDM2 amplification, and a MET exon 14 deletion. Based on these results, she was started on therapy with osimertinib and Capmatinib. After 2 months of therapy, partial response was seen, as is shown here. On the left, we see the CT at the time of osimertinib resistance and progressive disease. And on the right, we see a CT scan 2 months after the osimertinib and Capmatinib started, consistent with a partial response. We have multiple trials that support the combination of EGFR and MET inhibition in these patients, both following first and second generation, followed by osimertinib resistance, and also immediately following osimertinib in patients with MET-related resistance. The first study was the TATAN trial, and in those patients who received osimertinib and savolitinib, responses were seen in patients who were both EGFR T790M positive and T790M negative, those who had received prior third-generation EGFR TKI and those who had not. And those who had received prior EGFR third-generation and those who had received prior third-generation EGFR TKI therapy, response rate was 25%, and those who had not received prior EGFR TKI third-generation therapy, the response rate was 86%. Duration of response was prolonged in both patients with T790M positive and T790M negative disease. And in those patients, specifically post third-generation EGFR TKI, again, response rate about 30%. Another trial evaluating Capmatinib and Gefitinib in MET dysregulated non-small cell lung cancer with EGFR TKI resistance. Again, response rates about 30% with the combination, and these are heavily pretreated patients. The waterfall plot shown here with multiple cut points for MET amplification shows in general that those with the highest MET amplification had improved responses, and about 50% with those with gene copy numbers greater than 6. The phase 2 INSIGHT trial evaluated Tepotinib and Gefitinib for those patients with MET-positive, EGFR-mutated non-small cell lung cancer mechanisms of resistance. And again, response rates in about the 30% range, those with high MET amplification in the 40% range. Here we see progression-free survival by MET expression, and those with the highest MET amplification had the most prolonged progression-free survival as seen in the bottom graph. Multiple trials are evaluating EGFR and MET combinations for patients with MET amplification and MET alterations as a mechanism of EGFR TKI resistance. And again, response rates are generally around 30%, maybe higher in those who have very high MET amplification and those who have not received third-generation EGFR TKI therapy. Cabozantinib has also been evaluated in non-small cell lung cancer and in those with refractory EGFR-mutated non-small cell lung cancer with response rates of about 20%. We also see Amivantamab, the dual EGFR and c-MET monoclonal antibody, and about 5 of 9 patients with MET amplification had response in this trial. And these evaluations are still ongoing. So MET alterations are a viable target for EGFR tyrosine kinase inhibitor resistance. Early studies show that there's tolerability and efficacy using first and third generation EGFR TKI therapy in combination with selective MET inhibitors. With a hope to overcome or prevent this resistance, this strategy is moving into the frontline setting, and we await results. The definition and uniform testing of MET amplification is really needed to bring and standardize these results into the clinic. MET mutations and other alterations are also seen in EGFR TKI resistance and can be targeted. Strategies that use combination TKI therapy, bispecific monoclonal antibodies, and antibody drug conjugates are being evaluated in this patient population. Thank you.